my dear students. I'm Dr. Amrit Nasta, right here on conceptual surgery. And today we will be discussing a very important, a very high-yield, but a little complicated topic, that is hernia. So I have a nice list of questions for you to discuss. So let's try to finish all of them today. Try to react as quickly as possible so that we can finish all of them on time. It covers different aspects of hernia, but let me tell you, one hernia module is never going to be enough. You'll have to read a lot, you'll have to solve a lot, but at least I'll give you some basic perspective on the kind of questions that are frequently asked on hernia. All right, so let us begin with hernia, our favorite topic, frequently underestimated, but it's not that easy. There are many small things in hernia that we often encounter that we are never really sure of, especially when it comes to solving MCQs. So starting with inguinal hernia surgeries. About inguinal hernia surgery, all of the following are true except. So we are looking at which of these is an incorrect statement for inguinal hernia surgery. Hernia in children is treated with herniotomy. This is true or false? Absorbable mesh should not be used for surgery. Surgery should not be done unless patient becomes symptomatic. Surgery can be done by laparoscopy. Some statements are straightforward, you can easily eliminate, like surgery can be done by laparoscopy. Of course, this is true. So inguinal hernias can be operated by laparoscopy, can be operated by open technique. It depends on the preference, it depends on the clinical indications, the scenarios. So either ways can be done. Hernia in children is treated with herniotomy alone. This is true. Please understand, posterior wall repair for inguinal hernia. Whenever I'm saying posterior wall repair, which is either herniorrhaphy or hernioplasty, where I place a mesh, is typically required when the posterior wall is weak, which is typically done in adults or in children with weak posterior wall, which is very rare. So typically in children where the hernia is a congenital hernia, herniotomy alone suffices. Absorbable mesh should not be used for surgery. This is true. You want the mesh to remain, you want it to give a good reaction. So absorbable mesh is generally not used. Generally, the mesh that we use, if it is non-absorbable, it is going to be polypropylene, or it will be a dual mesh. Conventionally, we use these meshes depending on what surgery we are doing. In inguinal hernia, we use polypropylene mesh. In intraperitoneal repairs, we use dual mesh. So even by elimination, you can get the answer that surgery should not be done unless patient becomes symptomatic. This is false. As a surgeon, I always say, whenever there are multiple treatment options, medical, minimal invasive, or surgery, surgery should be the last resort for disorders where such treatments are possible. But let me tell you, for hernia, there is no medical surgery. There is no medical management. There is only one treatment. That is going to be surgery. So conventionally, for inguinal hernias, you don't wait for patient to become symptomatic. Even if it is an incidental inguinal hernia, even if it's an incidental inguinal hernia, the treatment is going to be surgery. Only thing is, how early do you want to do it? So it's a question of when. It's not a question of if. You always operate inguinal hernias. Some hernias can be left alone, like very large incisional hernias. In very morbid patients, you can leave them alone because the risk of surgery is too much. But for inguinal hernia, this does not hold good. So for inguinal hernia, the treatment is surgery, irrespective of symptomatic or asymptomatic. Only question is how soon. So a direct hernia, you can wait for some time because they may strangulate rarely. Indirect hernias, small defects, they strangulate faster. So it's a question of when. It's not a question of if. That's what I'm trying to say. So the treatment for inguinal hernias is always going to be surgery. I will just summarize the basic treatment for inguinal hernias. The basics of treatment. The three treatment options that I have available. The first one is going to be herniotomy. Now, herniotomy alone is the treatment for inguinal hernias in children, where I will do herniotomy alone. The second treatment option is herniorrhaphy. Now, in herniorrhaphy, I strengthen the posterior wall using local tissue. You must have done Bassini repair, Schuldeis's repair, nowadays Desarda repair. So herniorrhaphy in today's day and age is not done very conventionally for a lot of inguinal hernias. But if they ask you for sure a good place to do herniorrhaphy, it would be inguinal hernia in adults in infected setting, like a strangulated hernia. So if it's an infected setting, you would avoid placing a mesh. Nowadays, you can place biological meshes also, but they are expensive. And the third is going to be hernioplasty or mesh plasty. This is done for inguinal hernias in adults. All right, direct or indirect, hernioplasty is the treatment of choice, which can be done by laparoscopic approach or by open approach. So that is about treatment, basic principles of inguinal hernia treatment, depending on age. Now, this is a very core anatomical question. The ligament of Cooper used in surgery for femoral hernia repair is formed by which of these extensions of inguinal ligament? So it is formed by which of these extensions of inguinal ligament? So there are some basic principles that we need to know. Basic anatomy, which will help you solve these kind of questions, which I will show you in an image. Obviously, ligament of Cooper cannot be one of the options. They are asking you, it is an extension of which of these ligaments. Anybody knows what is the other name of inguinal ligament? If they want to screw you, they will give you they will just change the name. Even though it means the same thing, which I will also show you in the image. The other name for inguinal ligament is Poupart ligament. So if you hear the word Poupart ligament, don't get confused. It means inguinal ligament only. Okay, it means inguinal ligament only. Now they are asking you, Cooper's ligament is used for femoral hernia repair. Comes from which ligament? The answer is lacunar ligament, and I'll show you how. It's a very simple diagram to understand, which is very anatomical, which will help you understand some basic things which are hard to visualize otherwise. This is the ASIS, this is the pubic symphysis, and this is the pubic tubercle. My inguinal ligament goes from ASIS to pubic tubercle. Now, whenever I say inguinal canal and inguinal hernia, they will be over here, just above the inguinal ligament. Somewhere here is the inguinal canal. In this context, this is the inguinal ligament. So my inguinal canal will be somewhere here. So let's get the inguinal part out of the way. Now I'm talking about femoral canal, which will be somewhere over here, below the inguinal ligament, which you can see over here. So everything about femoral hernia occurs below the inguinal ligament in this space, where I have the femoral vessels laterally. So here will be the femoral vein, femoral artery, and femoral canal within the femoral sheath. So femoral hernia will come from here like this, which will be a retort shaped swelling. So femoral hernia is coming over here, little medial to the femoral vein and lateral to the lacunar ligament. This is the lacunar ligament. Now, where is the Cooper's ligament? This is inguinal ligament. Right, this is inguinal ligament. This is lacunar ligament, which is attaching itself to the pecten pubis. The extension of lacunar ligament over here, this is the Cooper's ligament. Right, this is the Cooper's ligament. It's also called pectineal ligament. So pectineal ligament is same as Cooper's ligament. This is all we need to know about the different ligaments and their anatomy. So when I have to repair a femoral hernia, first I will reduce it. Means I'll explore this area, reduce the hernia, excise the sac, and then I just have to close this opening over here. So how do I close this opening? One of the repairs I can do is I use the lacunar ligament and the Cooper's ligament and I suture it like this. So the defect will be closed. Now let me give you a word of caution. This was the repair that was asked in the question using this Cooper's ligament. I'll give you a word of caution. Whenever I am doing open femoral hernia repairs, one of which was this. There are many named repairs like low approach of Lockwood, mid approach of Lothiason, and high approach of McKeevedy. You just need to know the names. You may have done some of them in your residency. All of these are open femoral hernia repairs. Mind you, these are just types of herniotomy. Okay, these are just types of herniotomy. What I'm trying to say is, for femoral hernia, placing a mesh is not the norm. You don't place any mesh over here. Because understand there is no posterior wall weakness. In inguinal hernia, this part is weak. So I place a mesh over here. In femoral hernias, placing a mesh in open femoral hernia repair is not the norm. All of these repairs are non-mesh repairs. They are like herniorrhaphies or modified herniorrhaphies. They are local repairs. There is no mesh plasty in them. Okay. When we do laparoscopic inguinal hernia, since we are seeing the femoral ring, we place a mesh, but that's only a laparoscopy. In open femoral hernia repairs, mesh is not post. They are basically local repairs because there is no weak posterior wall that has to be strengthened. Okay. Now, based on that principle, for differentiating inguinal hernia from femoral hernia, what is going to be the landmark? Is it going to be pubic symphysis, femoral artery, inferior epigastric vessels, pubic tubercle, or femoral ring? What is the landmark? It is based on what I just showed you, that inguinal hernia will be above inguinal ligament, somewhere here. Femoral hernia will be below inguinal ligament. How do I delineate inguinal ligament? ASIS to pubic tubercle. So femoral canal or femoral defect will be inferior to pubic tubercle. Inguinal hernia will be superior to pubic tubercle. So the answer here is going to be pubic tubercle.